Thank you for the very kind introduction and very good morning, ladies and gentlemen. It's a privilege to be able to meet all of y'all at this wonderful virtual platform. And I'd like to thank the organizers, especially the Pharmaceutical Services Division of Hospital Kuala Lumpur, for not only inviting me to speak, but for coming up with this wonderful program to commemorate the Antimicrobial Awareness Week, which I think is extremely important. So ladies and gentlemen, I've been given the task to speak about antibiotic prophylaxis in obstetrics. I'd like to declare that I've got no conflict of interest in this talk. Ladies and gentlemen, what do I intend to cover? I'll be covering facts. I'll be covering preterm deliveries and antibiotics. I'll be talking about GBS, about SBE prophylaxis. I'll be talking about antibiotics for cesarean section, everyone's favorite. And finally, I'll talk about what is new, what is not recommended, what is controversial, and finally, I will summarize all of which I intend to achieve in the next 25 minutes. So let's take a look at some facts about antibiotics prescription in pregnancy. But let's first appreciate the principles of prescription in pregnancy. Ladies and gentlemen, it is not easy to prescribe in pregnancy, but we are often too fetal-centric. We are often too risk-centric. And the only guideline we quote is the FDA recommendations. But ladies and gentlemen, that should not be the way. We as clinicians should balance the benefit against risk ratio. There may be some small studies, there may be some case control studies showing risk, but we must appreciate that the evidence continue to evolve. I believe at what gestation you prescribe, at what dosage you prescribe is important, rather than just saying it is not safe. You also need to appreciate the wonderful placental and breast milk barrier, one of the most important and efficient barriers, and hence what we perceive as a risk to the fetus may not actually be so. And please do not merely quote FDA. It is a classification of risk. It is not a classification of benefit against risk. And ladies and gentlemen, these, I believe, are the principles of prescribing in pregnancy and holds true for antibiotics as well. So let's take a look at some antibiotics which are not preferred. Now, I, for one, believe that there are no single intervention and there's no single antibiotics which is contraindicated in pregnancy. If you think it is important to save the mother's life, administer it. However, if there's a safer option, choose the safer route. So which antibiotics which are not preferred? Number one, aminoglycosides, especially streptomycin, because it is linked to fetal hearing loss. That is followed by tetracyclines, because this causes some discrystallization of the tooth and some bone abnormalities. Now, folate antagonists such as trimethoprim and sulfamethoxazole, also not preferred. Fluoroquinolones and polymyxins are among the other antibiotics which are usually not preferred. I'd like to bring you all back to 2002 to this wonderful paper which changed practice, that is known as the Oracle trial. Published in 2002, there were two important summaries from the Oracle trial. This showed for patients with preterm, prelabel rupture of membranes, if we give them erythromycin, it is safe, there's prolongation of pregnancy, there's neonatal benefits, it reduces infection. Similarly, it also showed that patients who were given co-amoxicillin or augmentin, there's an association with neonatal necrotizing enterocolitis, and hence, it is also another antibiotic which is not preferred in pregnancy, thanks to the Oracle 1 study. However, ladies and gentlemen, I would also like to highlight and bring your attention to a more recent controversial paper published in the BMJ in 2019 by Heng Fan et al. Now, this paper changed practice and caused a significant controversy and alarm. It was for the first time published that there was an association between macrolide antibiotics with adverse fetal outcomes, especially in the first trimester, and this was a single population-based cohort. So for all the patients that were given macrolides in the first trimester, for some unknown reason, there was an increase in cardiovascular malformations, especially ASDs. There were also increase in genital malformations. Now that caused a significant concern, but fortunately now, ladies and gentlemen, there are more and more papers that shows that macrolides is not associated with fetal abnormalities or fetal cardiac defects. But this was one paper which caused some alarm 2 years ago. With that, ladies and gentlemen, for a fact, certain antibiotics are not preferred. Co-amoxicillin, there is an association with NEC. Macrolides and fetal abnormalities are no longer true. I'm going to move on to the next part of my talk, antibiotics and preterm labor. Ladies and gentlemen, among the many causes of preterm labor, the cause number one, the leading cause, is infection. And we often strive hard to prevent preterm labor by preventing an infection. So let's first take a look at screening for asymptomatic bacteriuria. Now, I'm sure many of you all can still appreciate that this remains controversial, but this is no longer controversial among pregnant mothers. Now, the Cochrane review thinks that if you screen and treat mothers for asymptomatic bacteriuria, there's a significant reduction in preterm labor. So yes, ladies and gentlemen, screen for it for pregnant mothers, irrespective of the risk, treat them, you may be able to reduce preterm labor. I would like to bring your attention to another paper, the American College of Physicians guidelines titled Asymptomatic Bacteriuria in Adults. They clearly come up with a statement that pregnant women should be screened for asymptomatic bacteriuria, especially in the first trimester. If screened positive, they should be given antimicrobial therapy for 7 days. So that is the evidence, ladies and gentlemen. Screening is recommended. There are fetal benefits. Now, the NICE guidelines 2018 with regards to UTI in pregnancy recommends the antibiotic of choice. The antibiotic of choice in pregnancy is nitrofurantoin. It is contraindicated in the third trimester, but it is safe in the first 2 trimesters. So what is the dose? 50 milligrams QID for 7 days. Or if you have a modified release preparation, you can give 100 milligrams BD for 7 days. Now, the second antibiotic of choice, if the patient has got anaphylaxis, the patient has got some concerns, or if the patient is in the third trimester, then you can give cefalexin 500 milligrams BD for 7 days, or amoxicillin 500 milligrams TDS. Now, ladies and gentlemen, if the patient has got a recurrent, more than 2 episodes of culture positive infection, then the recommendation is daily prophylaxis antibiotics with the aim of preventing a preterm labor. And the recommendation is to continue throughout the antenatal period up till delivery. And that is what is being recommended by most guidelines. Now, controversy number 2, moving away from asymptomatic bacteriuria is GBS. Ladies and gentlemen, GAS, group A streptococcus, is the leading cause of maternal deaths in the world, but the leading cause of neonatal deaths, neonatal sepsis, and morbidity and preterm labor is GBS. Unfortunately, as of now, the world is still divided with regards to universal screening. But I, for one, will advocate universal screening just by sending a urine culture. Now, if you have a GBS on a high vaginal swab in the antenatal period, there's no need to treat. But if you have GBS in the urine at the antenatal time, the recommendation is to treat with 1 course of antibiotics and also to treat intrapartum to reduce the risk of infection to the baby. The world is divided, but I, for one, believe this is the way forward. We need universal screening. The current concerns against screening is resources, availability of a sensitive culture media, and how accurate can you pick up GBS But I believe these are concerns that we can address. There's always a sensitivity and a specificity of a test. Moving on to the third infection, ladies and gentlemen, is bacterial vaginosis. The world is clear. Screening for GBS is beneficial. But is there a risk and is there a need to screen for BV? I'd like to bring your attention to this JAMA paper titled The US Preventive Services. It is clear, ladies and gentlemen, there's no role to screen for bacterial vaginosis universally among all pregnant mothers. But is there a need to screen among high-risk women? I think it is still controversial, but the general consensus is no. Now, BV, for many years, the antibiotics of choice was metronidazole, but this New England Journal of Medicine, published almost 2 decades ago, cleared the air. There is no benefits of metronidazole to treat BV. It does not prevent preterm labor. After this paper, we changed, and throughout the world, we used to prescribe clindamycin with regards to preventing and treatment of preterm labor. However, ladies and gentlemen, the PREMAVA study, recently published in the Lancet, titled Early Clindamycin for Bacterial Vaginosis in Pregnancy. It was a multi-centered, double-blinded, randomized controlled trial study. And this study showed that if you give early clindamycin, there is no reduction of preterm labor, there's no reduction in miscarriage, there's no benefits of early clindamycin use. So ladies and gentlemen, there's no benefits to screen BV, metronidazole, no benefits, clindamycin, no benefits. So with that, I'm going to move on to another clinical conundrum called cervical cerclages. Antibiotics are not recommended for elective cerclages, but antibiotics are recommended for rescue cerclages. You can divide rescue cerclages into 2 groups. One, where the membranes are bulging at the level of the external os. The incidence of infection can be as high as 50%. You may offer cerclage. Now, 2 is a slightly more complex group. The membranes are now not at the external os. The membranes have protruded into the vagina. Current recommendation is not to offer cerclage, but is to do an amniocentesis, is to look specifically for interleukin-6 and to treat with antibiotics, because the risk of infection can be as high as 59%. So yes, ladies and gentlemen, group number 1, electively no antibiotics. Group number 2, membranes at the external os, cerclage. Group number 3, membranes beyond the external os into the vagina, antibiotics to prolong the pregnancy. So antibiotics and preterm labor, ladies and gentlemen, the current consensus is to give every single pregnant mother who presents in labor with ruptured membranes antibiotics, namely to prevent GBS. Because screening tools are insensitive, the recommendation is to treat. Now, Oracle 2, way back in 2002, showed no benefits of antibiotics if a woman presents with preterm labor with intact membranes. But the recent NICE guidelines and RCOG guidelines recommends antibiotics for all preterm labor, irrespective if your membranes are ruptured or your membranes are intact. And that brings to the management of preterm pre-labor rupture of membranes. So what antibiotics should you give if a mother has got a preterm pre-labor rupture of membranes? We can extrapolate from the Oracle 1 trial. And the recommendations, ladies and gentlemen, is erythromycin, 250 milligrams BD for 10 days. There's a significant reduction in neonatal infection. There's a significant prolongation of the pregnancy. It is safe, and that has been a practice for the last 2 decades. Now let's move away and let's talk about GBS. So if the mother presents with preterm labor, give antibiotics. The mother presents with PPROM, it is erythromycin, antibiotics of choice. But if the mother presents in labor, and if you think the mother has got GBS, now based on the CDC guidelines, the antibiotic of choice is penicillin. Now, the recommendation is penicillin G, which is to give 2.5 to 3 million units every 4 hourly, not 6 hourly, 4 hourly, because you have to reach a plasma steady state. The second choice is ampicillin. Now, which is superior, ladies and gentlemen, penicillin or ampicillin? The recommendation is penicillin because if you are too broad, ampicillin, you may kill some normal flora, and that may cause a more worsening of gram-negative sepsis. So better antibiotics does not mean you are doing benefit, you're actually doing more harm. Antibiotics of choice is penicillin. However, the patient has got penicillin allergy. The next antibiotics is clindamycin. If the patient is not susceptible to clindamycin, then the recommendation is vancomycin. So ladies and gentlemen, a stronger, broader antibiotics is not recommended. Penicillin works wonders, and that is the CDC recommendations for GBS. Now next, talk about bacterial endocarditis. For many years, almost all patients with cardiac diseases, it is common for them to have antibiotics in labor, but the American guidelines and the NICE guidelines now only recommends 4 groups of women to have SBE prophylaxis. Group number 1, women with an unrepaired cyanotic heart, woman who's got a prosthetic material device, woman who has got a repaired congenital heart but a residual lesion. This woman needs SBE prophylaxis. The second group is a woman with a prosthetic valve. Yes. A woman with a previous infective endocarditis. Yes. And finally, a woman with a cardiac transplant. Now, these are the 4 groups of women. So please do not abuse antibiotics, because they realize that the incidence of infective endocarditis among women delivering vaginally is extremely low. The risk of resistance and anaphylaxis is way higher than the risk of infective endocarditis. The antibiotic of choice is not gentamicin, it's purely ampicillin 2 grams, or you can give first generation cephalosporin. The mother is allergic, you can give clindamycin 600 milligrams. You don't really need gentamicin coverage. Now with that, ladies and gentlemen, let's move on to everyone's favorite topic and controversy, antibiotics for cesarean section. I'm going to summarize the entire slide on cesarean section in one slide. The recommendation is 1 dose, not 3 doses. The recommendation is a broad spectrum antibiotics which covers gram-positive and gram-negative, not too broad. So first generation cephalosporin. You don't really need a metronidazole additional. Co-amoxicillin, because of the issues with NEC, is not recommended. Now, when should you give antibiotics? It should be 30 minutes prior to skin incision, not after clamping the cord, but 30 minutes prior. It was a common practice to give antibiotics after the delivery of the fetus because they were worried about anaphylaxis causing fetal distress. They were worried about the passage of antibiotics to the baby and the effects of antibiotics to the baby. The current evidence, ladies and gentlemen, not after cord clamping, 30 minutes prior to skin incisions. Now, if the mother is obese, the mother is of higher BMI, you need a higher dose. And if the surgery is prolonged beyond 3 hours, you need to repeat another dose, although most of the time you need a single dose. However, the mother is already on antibiotics for some other reason, especially for GBS prophylaxis, you don't need to give additional antibiotics. As long as it is given within 2 hours, you can continue the same penicillin and do a cesarean section. The mother is allergic, you can give clindamycin. The mother is an MRSA colonizer, you can give vancomycin, not vancomycin alone, but vancomycin plus cephalosporin. So ladies and gentlemen, not just antibiotics, I would like to bring your attention to this paper by the Cochrane review that showed how you clean is also important. And over the years, vaginal cleaning has been shown to reduce the incidence of endometritis. So clean the abdomen with chlorhexidine, but clean the vagina with povidone, especially with women in labor, as a significant reduction in infection. But that brings to the next point, vaginal seeding. So ladies and gentlemen, there's been a debate about the implications and the risk of an elective cesarean section. And they now know that babies born via an elective cesarean section has got a higher risk of atopy, eczema, type 1 diabetes, autoimmune diseases. And the postulation was 2, because they are not exposed to the vaginal flora, and sometimes they are, and they were given antibiotics that kills the normal flora. So there was a consensus that after delivery via cesarean section, you wipe the baby with a cloth taken and damped with the vaginal secretions, and that is known as vaginal seeding, which has been postulated to be beneficial. However, as of today, ladies and gentlemen, there's no evidence to say that vaginal seeding improves fetal outcomes. It is not recommended, but it's good practice not to abuse antibiotics, because the vaginal ecosystem plays a significant role in fetal outcomes. So with that, ladies and gentlemen, do you have to give prolonged antibiotics for mothers who have got meconium-stained liver? Does antibiotics actually reduce infection on the baby and for the mother? The answer is no. The mother's got a meconium-stained liver. There's no need of additional antibiotics, apart from the routine coverage for GBS, if GBS, and a single dose for cesarean section. So what are the other obstetric procedures that need antibiotics? I spoke about cesarean sections, but if the mother's got a complicated cesarean section, you need to give a longer dose of antibiotics. The mother's got a 3rd and a 4th degree perineal tear, antibiotics is recommended. And ladies and gentlemen, a new recommendation is antibiotics for all instrumental deliveries. This was not a standard of care, but a recent paper called the ANOTE trial now recommends instrumental deliveries, antibiotics, a broad spectrum. It significantly reduces the incidence of endometritis. Now, what are the procedures that you do not have to give antibiotics? Elective cerclages. Rescue cerclages, yes. Elective cerclages, no. MRPs, manual removal of placentas, you don't need antibiotics. Cervical tears, you don't need antibiotics. Episiotomy and perineal lacerations, there's no benefit of antibiotics. So what is new, ladies and gentlemen? I would like to highlight 3 things. We are progressing towards the point of care testing for GBS. We now know that antibiotics is one option for patients with cervical insufficiency where the membranes are bulging into the vagina. And we now know that antibiotics is recommended for instrumental deliveries, not just cesarean section. So imagine a point of care of testing. A woman presents in labor, you do a swab. In the instant, you can identify that she's got GBS, you give her antibiotics. But if a woman presents in labor, she's got prolonged leaking, she's not a GBS carrier, there's no need for antibiotics because that might cause more fetal harm and a higher risk of neonatal sepsis as compared to giving antibiotics. And it seems to be the future. I'm sure it'll change the way we practice obstetrics. Similarly, ladies and gentlemen, the world were unaware of a disease called COVID-19. The world developed a vaccine within 8 months. I'm sure one fine day we will also develop a GBS vaccine. And perhaps by vaccinating every pregnant mother, we may reduce the implications of neonatal death and sepsis. An important new paper published in the American College Journal of ONG, also known as the Green Journal. Now, in patients with cervical insufficiency, where the entire sac is bulging into the vagina, a traditional approach was to cerclage, but this paper by this group showed that by doing nothing, by giving 3 antibiotics, there's a significant reduction in intra-amniotic infection and inflammation, and there was a progression of pregnancy, which was managed expectantly. So by giving antibiotics, by giving a combination of ceftriaxone, clarithromycin, and metronidazole, there was a resolution from the membranes which was protruding into the vagina, back into the uterus, and they continued and managed the patient successfully to a safer gestation. And this now seems to be the way forward. There is a role of antibiotics to prolong pregnancies in this small cohort patients. Another option is to do an amniocentesis check for interleukin-6. If interleukin-6 is positive, treat with antibiotics. If interleukin-6 is negative, do a cervical sublux. And the third group, ladies and gentlemen, is this paper called the ANOTE trial, which was published in the Lancet. It was a multi-centered randomized controlled trial. Now, the ANOTE trial showed by giving a woman a single dose of amoxicillin, there was a significant reduction in endometritis. And I believe this is the way forward. For all patients undergoing an instrumental delivery, a single dose of antibiotics is beneficial to the mother with regards to chorioamnionitis and endometritis. So what is not recommended, ladies and gentlemen? I'd like to talk about these 5 things which are not recommended. Key point number 1, if a woman undergoes a surgical management of miscarriage, there's no benefit of antibiotics. And that's been proven based on a randomized controlled trial study. The evidence is strong. However, if the woman undergoes a termination of pregnancy, if the woman undergoes an abortion, antibiotics is now recommended because you need to cover for chlamydia. The recommended antibiotics is 100 milligrams BD of doxycycline. Not for all patients undergoing surgical management, but for a selective group of patients undergoing a termination of pregnancy. Now, what is also not recommended? If a woman presents with PPROM, antibiotics for GBS. If the woman presents with leaking and GBS, yes, antibiotics. But the woman presents with leaking at term, there is no benefit of antibiotics. It causes more harm than good. It causes a higher incidence of gram-negative sepsis. There's no benefit of antibiotics. And hence, this strengthens the fact about the importance of GBS screening. Screen at booking, treat if it's positive in the urine, screen based on a low vaginal swab and a rectal swab at 34 to 36 weeks. If positive, treat with penicillin intrapartum. If it's negative, there's no need to abuse antibiotics. And finally, ladies and gentlemen, the timing of administration of antibiotics during cesarean section, as highlighted earlier, it is not after clamping of the cord, it is 30 minutes before the skin incision. There's also a study showed that apart from a single dose of first generation cephalosporin, adding an adjunctive azithromycin significantly reduces the incidence of infection following a cesarean section. Now, this is not a practice which is routinely practiced, but you may consider in certain selective group of patients, whereby adding azithromycin, you significantly reduce the incidence of infection during cesarean section. Finally, ladies and gentlemen, the controversies of probiotics. I would like to highlight your attention to this wonderful paper published in the BJOC about microbiome and women's health. We do know and appreciate that vaginal flora plays an important role with regards to the long-term immunity of the fetus, with regards to preterm prevention, with regards to well-being of the mother and constipation and discharge and asthma. But as of today, there's inconclusive evidence to recommend probiotics, ladies and gentlemen. But what is important, do not abuse antibiotics. Maintain the woman as near normal, healthy, and natural, as positive, as better as possible. Do not abuse probiotics, do not abuse antibiotics as well. So with that, ladies and gentlemen, I would like to conclude. Be cautious with the use of co-amoxicillin. Aminoglycosides, tetracyclines, but macrolides are safe. The way forward, we need to screen for asymptomatic bacteriuria, screen for GBS, but there's no role of screening and treating BV for preterm delivery. If a woman is undergoing cesarean section or instrumental deliveries, first generation cephalosporin is recommended. An adjunct of azithromycin is beneficial. You don't really have to give SB prophylaxis for all mothers. There are 4 criteria. It is limited. The risk from SB prophylaxis far outweighs the benefits. Do not abuse antibiotics because the maternal and fetal implications are significant. So with that, I would like to end with a quote that the greatest medicine of all is teaching people how not to need it. And the greatest challenge in modern medicine is to educate the staffs about when not to abuse antibiotics. So with that, ladies and gentlemen, I would like to thank you so much for your kind attention. I'd like to end that it is not always the risk, but it is a balance between the benefit and risk ratio, and then make a decision. With that, thank you so much for your kind attention. And I'll be more than happy to take your questions.